Singapore will be offering vaccines to healthcare workers whom are at greatest risk of encountering Mpox. The vaccine will also be offered to close contacts of confirmed cases. But Health Minister Ong Ye Kung says there are no plans to elevate the country's response further. That is, as its people can manage what he described as a troublesome virus due to experiences gained from the COVID-19 pandemic. Nicolas Ng with more.
You got it.
This variant of Mpox, called Clade 1, led the World Health Organization to declare a global public health emergency. The Singapore Health Ministry has responded with a plan that doesn't have a circuit breaker or mandatory masking, yet. Experts say this is the right approach.
Mpox is very different from COVID. It doesn't spread as easily as COVID. To have a response more severe than what we currently see would be similar to taking a sledgehammer to hit one small ant.
As safeguards, authorities have started testing wastewater from migrant worker dormitories. That's on top of temperature and visual screening at airports since August. Suspected Mpox cases will be tested by authorities and transferred to hospitals, while contact tracing begins. Vaccines are also being offered to healthcare workers who have to attend to people with Mpox, as well as close contacts. The vaccines are from the country's existing stock for smallpox, which experts say is still effective.
Smallpox and Mpox are both in the same family of viruses, the technical name being orthopox virus. And so the vaccine against smallpox actually provides 80% protection, approximately, to Mpox infection.
It's for this same reason that people born before 1981 will have some protection from the virus, which one can easily check.
Just in case you all want to check, is on your left. This little wrinkle. This little wrinkle oval-shaped scar, that is smallpox.
He said the current stock of such vaccines in the country is enough, but will eventually run out.
We do have to watch the stock. Based on our current response plan, which we think is a correct one based on the characteristics, we have adequate supply. That lasts us quite a while. Of course, if we change response to say offer it to everybody, then of course you're not going to have enough. No country have enough.
Authorities will monitor how the virus is transmitted and may change the countermeasures as the situation develops over time.
And for more analysis on this, we are now joined by Professor Dale Fisher from the NUS Yong Loo Lin School of Medicine. He is also director of the NUS Centre for Infectious Disease Emergency Response. Professor Fisher, thank you very much for joining us this hour. So the health minister there expressing confidence that Singapore can manage Mpox infections even if we were to have Clade 1 infections. What are the factors and characteristics of Singapore's public health emergency response plan that are enabling this confidence, Prof?
Yeah, thanks, Shahida. The confidence is well justified in my view. There's many reasons why Singapore can respond to outbreaks so well, and it really comes down to the strength of the pillars of outbreak response. There's several aspects to an outbreak response that we have to prepare, and you can see many of these getting exercised here. We've got great surveillance in Singapore. I see, they're upping the airport surveillance. They're going to be doing wastewater testing. So with good surveillance, you can detect cases early, you can implement the contact tracing, you can quarantine the contacts and even vaccinate the contacts to allow them to avoid severe disease. On other fronts, in terms of these pillars of outbreak response, the community engagement is very strong in Singapore. The community should have good knowledge of how to protect themselves. And I think there's just a frank understanding that the government follows the science and implements these interventions in proportion. Infection control is very strong in hospitals compared to other countries. We've got good isolation capacity, good PPE supplies, staff are well trained in infection control. our laboratories. They're able to do the tests, and they're also able to scale if we get more. So because of our preparedness over decades, probably since SARS-1 in 2003, we've developed these capacities. So therefore, when there's a threat like this, we can respond pretty effectively.
Based on the current understanding of this virus, Prof, MOH has said that population-wide Mpox vaccination is not recommended for now. Mask wearing is also not recommended for those who are well. What about individuals or families who want to seek out and arrange their own vaccinations as a precaution? Are there medical factors to consider?
Yeah, so firstly, it's not indicated for the general public simply because most people aren't at risk. For instance, there's probably no cases in Singapore at the moment. Maybe there's one or two that have been imported, but there's no local transmission. So you do widespread vaccination if you've got a disease that's highly transmissible or produces very severe disease. So if you look at some of the vaccines like COVID, measles, these are diseases that are spread very quickly. Then there's others with severe consequences like polio and whooping cough and rubella. So you've got to, when you make a decision on vaccination, there has to be a good reason and an understanding of the science behind it. As far as mask wearing, we don't believe respiratory secretions are a major source of transmission, and certainly not in asymptomatic disease, people without even a fever. But however, respiratory secretions probably play a minor role. The major role is in skin to skin or mucosa contact, particularly if the skin's broken, and that's why we see these skin lesions. But now that we're seeing more in children with this clade 1b, we have to start to postulate that it's coming from carers or there's some playground spread at schools or something. So we're learning more about why 1b is going to be more transmissible and possibly more severe. So the other reason about the vaccination is that there's a worldwide shortage. So decision makers really have to be prudent about where it's used and make it available to the most needy people, and the ones where they're going to get the best value are those that are contacts that are likely to develop infection.
Yeah, and as we learn more about this virus, Prof, we also heard earlier Minister Ong expressing confidence too that Mpox is very unlikely to lead to the kind of disruption that happened during COVID-19. Help us understand the difference between Mpox and COVID-19. After all, both are infectious diseases that can spread through human contact and interaction, and they can also spread across countries because of global travel.
So if you remember during COVID, we first realised imported cases that had come from Wuhan and later more of China. And then we started to get local clusters. You remember some of those early in 2020 in Singapore. And in other countries, it really spread to rampant community transmission where you don't even know where it came from. And we're just not seeing the rampant community transmission. By the time Omicron came, there were each case would probably affect 9 or 10 other people as the natural history. Mpox, it's much closer to one, so one person will infect one other person. So it's much harder for the outbreak to really get going from the outbreak point of view. Of course, when we knew we couldn't eradicate COVID from the world, we had to get vaccination and then introduce it slowly so that it wouldn't overwhelm health systems. This is the biggest thing. If you've got a disease that can overwhelm a health system, so therefore more people die, so therefore, and they die of other conditions, we can't even look after heart attacks properly. That's the threat that COVID gave us. And that's why we had to have such extreme interventions. And that's why none of us see this threat with Mpox, so you're not likely to see the same extreme interventions, if you like. They're not necessary.
Professor Fisher, appreciate your insight as always. Thank you very much for that. Professor Dale Fisher there from the NUS Yong Lin School of Medicine. and NUS Centre for Infectious Disease Emergency Response.